Hi, everyone, and welcome to another episode of the All Things AFib podcast. I'm really looking forward to our conversation today. Our guest today is a distinguished electrophysiologist who completed his training at the MGH, Harvard Medical School in Boston, Massachusetts. He's not only been a prolific clinical EP, but also an EP scientist with nearly 100 peer-reviewed articles, and he's an absolute rock star in the space of cryotherapy for atrial fibrillation. He is the current principal investigator for the PIVoTAL IDE study, and we'll get into that in a little bit. And he's been practicing at the Mercy Medical Group in Sacramento, California since 2015 and is the current chair of cardiology and cardiovascular surgery at the Dignity Health and Vascular Institute at Mercy General Hospital. So I thought, who better to help us understand cryotherapy for atrial fibrillation? So thank you so much for joining us today, Dr. Arash Aryana.
Thank you for this opportunity to be here, and thank you for your kind introduction.
Sure. So let's just start off. So let's talk about cryo in a kind of very fundamental terms. So why cryo? You know, it's interesting. In surgery, we started with the cut and sew maze, and then actually Dr. Cox will tell you for 4 lesions in the cut and sew maze, he used cryo. So talk to us about how did cryo start in the endocardial world in EP?
Thanks for asking that question. So as you are correct in suggesting, radio frequency ablation has been essentially the main workhorse, the cornerstone of how AFib ablation has been performed over the years, and not just AFib, but also other types of ablations. The one unique feature of the cryo balloon ablation is that it actually has a much larger footprint, as it turns out, in making lesions than old-fashioned radiofrequency ablation. In other words, in various studies, when compared head-to-head against a point-by-point radiofrequency ablation, which is the nature of how radiofrequency ablation is performed, using a delivery, and the such delivery system involves a focal catheter that delivers it in a point-by-point fashion. When we compare lesions, the lesions are sometimes as much as 4 times as wide when created with a cryo balloon catheter. And that happens to be more of a unique feature, if you would, or a characteristic of that delivery system. In addition to that, there are also other advantages potentially associated with cryo versus RF, radiofrequency that is, and one of which being, as we've seen in various types of studies, that the safety associated with cryo ablation in the left atrium appears to be better than that of radio frequency. For instance, there are a number of studies dating back to as far as 1990s and early 2000s demonstrating the safety of this, including, for instance, the reduced risk of a blood clot or thrombus formation inside the left atrium. There is a perceived benefit of a reduced incidence of fistula formation or stenosis of vasculature. One of the targets of AFib ablation, as you may know, is the vascular system, the pulmonary venous vascular system, the pulmonary veins, that is. And pulmonary vein stenosis is something that is seldom seen with cryoablation, but can occur with radiofrequency as well. So there are certain safety benefits, potentially. Having said that, there are other types of unique features associated with cryoballoon ablation, which one has to be mindful of. For instance, it has a higher tendency sometimes to cause certain complications such as phrenic nerve injury, the nerve that goes to the diaphragm. And so one has to be mindful of that. But overall, all in all, it has proven to be a bit better, easier workflow, streamlined better than radiofrequency in some ways. And it has also emerged as a better tool for making larger applications, especially in some areas like the posterior wall. Now, the posterior wall is something that I'm going to segue into later in the course of this discussion as well, when we're talking about the PIVoTAL IDE trial. But this is something that we've actually acquired and learned from you, the surgeons, that is, the cardiac surgeons. Over the years, we've known that the advantage of ablating the left atrial dome, as it's known as in the cardiac surgical realm, what we call the posterior wall, so to speak, or the pulmonary venous component is another term for it, is a crucial part, a component of ablation of AFib, for sure when ablating persistent and long-standing persistent AFib, but also probably it plays a role in other forms of AFib, perhaps even including paroxysmal. So the workflow is what really makes it such an attractive piece.
So, I mean, as far as the usage of cryo, I mean, what percentage, just guesstimate, do you think EPs are using exclusively cryo versus cryo RF versus only RF?
So good question. Cryoballoon ablation was just approved 6 months ago as first-line therapy for the treatment of AFib, and it's the only modality currently approved as first-line therapy. So I'm guessing probably the numbers have been rising and probably even on the rise as we speak. But I don't have a good estimate on that. I would probably have to guesstimate and say something like about 30–40% of the cases are done with cryo. Probably about 60–70% historically have been done with radiofrequency. And that may have changed in the last year or two, and it may be changing as we speak. But there's a lot of times the need for using both cryo and radiofrequency in conjunction to one another to achieve the endpoint that's desired.
And something you had mentioned earlier, which I thought was interesting, you talked about how cryo is well suited for pulmonary vein isolation because of the balloon, the size, in order to create kind of the orifice and antral lesions. But then, do you feel like as EPs take on more of the persistent, long-standing persistent populations, that cryo will even be more popular? Because again, like you had said, it may be a better tool for posterior wall isolation or posterior vein component ablation.
Certainly there seems to be a increased adoption of it, widespread adoption and growing as we speak. But to be also fair and frank, there was also there are other advantages to other modalities that are on the horizon. For instance, pulse field ablation, as you are well familiar with. So time will tell as we evolve and the technologies and tools that evolve with us, whether cryo will continue in that trajectory. But so far, I think it's fair to say that the utilization of cryo for treatment of persistent AFib and creating large lesions has definitely grown and will continue probably to grow until other modalities like PFA or pulse field ablation take a strong hold in that space.
Absolutely. And so I was going to ask you about that. As far as combining PFA with cryo, do you see any limitations in that space? Would that be something that would be staged? Can you shed some thoughts on that for us?
Right. So one of the advantages potentially of PFA or pulse field ablation is that it does not have certain safety issues that are associated with radiofrequency and cryo. For instance, as we said, phrenic nerve injuries is more commonly seen with cryoballoon ablation historically, and also esophageal complications are something that we fear the most, and they can both be encountered by both cryo and radiofrequency. Some might say their incidence may be lower with cryo. It's never been proven, but we do believe that PFA or pulse field ablation or electroporation essentially is probably at least has a higher threshold for causing such complications. Perhaps even some have claimed that it's really difficult to do that altogether with this modality. So time will tell, but I think as time evolves, our technologies are going to get safer and probably more efficacious as we go as well.
Right, right. Something that you had mentioned in a great article, I just want to make the listeners aware of. It's entitled "Rationale and Outcomes of Cryoballoon Ablation for the Left Posterior Wall in Conjunction with Pulmonary Vein Isolation." This was actually published in the Journal of Innovations in Cardiorhythm Management just earlier this year in 2021. Something that you had mentioned in there that really caught my eye was this idea of myofibril heterogeneity in the posterior wall. And at our center, we perform a lot of hybrid, if you will, ablation approaches. Do you think that would lend itself more to a hybrid approach with the cryo endocardial and then maybe an RF epicardial?
I think the hybrid approach is certainly an attractive approach. There's no argument about it. There are potential advantages. For instance, the surgeons like yourself can tackle the posterior wall, as the electrophysiologist perhaps can go through and mop up what hasn't maybe been completely ablated, or to additionally target other sites, let's say the cave or tricuspid isthmus or basic pulmonary vein ablations or so on. So I think there is certainly at many experienced centers like yours, there's a valuable rule rationale for doing it that way. In fact, one could argue that there's even data that suggests there are perhaps epicardial myofibrils on the posterior wall. We've done some studies at our site to demonstrate, again, using the cryoballoon, we probably can create durable long-term lesions that are transmural, because that part of the posterior wall is not that thick, as you'd agree, I'm sure. It's only about a couple millimeters thickness. But nonetheless, I think having that extra sort of support and ability to ablate it epicardially lends more success to it, I think.
Another area that, a lot of us in the field are quite excited about is the left atrial appendage, whether it's epicardial closure with LAOS, endocardial closure with amulet or Watchman. There's also these conversations that are happening about intentional left atrial appendage isolation, whether it's with PFA, whether it's with RF. Can you talk to us about how cryo fits in that space with left atrial appendage isolation?
It's a great question. I think this is one of those areas where we have some conflicting data, to be honest. There are several studies that have shown potentially beneficial outcomes associated with isolation of the left atrial appendage. The most recent study, which I'm sure you're very familiar with, is called the AMAZE trial. And
Right.
that specifically looked at the ligation of the left atrial appendage epicardially by silencing and essentially ligating the appendage. Essentially, the idea was to see if we can see beneficial incremental benefits to AFib ablation outcomes. And there wasn't any. It really didn't add anything further to that. So there are some conflicting data out on this. The only, if you've seen some of the work that we've published, the only advocacy that I've had on this is I've said in the past, if we're going to be closing the appendage, let's say in a manner where we're going to be deploying, let's say, Watchman or an amulet or an endocardial occlusion device in these patients, and we are ablating them, I think it's not a bad idea to isolate the appendage empirically in that patient population, purely because if there are any arrhythmias that arise from that structure, once you put a device into it, it becomes extremely difficult to ablate that. We recently performed a procedure, we're in the process of publishing it, where we actually had to go epicardially, to your point, to ablate it because endocardially there was a device occupying that space, so to speak. So we ended up taking the route of going through the coronary sinus and distally ablating it epicardially. Now we happen to be a little bit lucky in this case where the vein branchology, so to speak, or branches of the coronary sinus were conducive to that. But if that wasn't the case, then we'd be relying on having to do surgery, open heart, or other types of strategies. So I think that's the only time when I empirically isolate the appendage on a regular basis. The data to me has not been compelling enough to argue ablating or isolating or closing the appendage on a routine basis. Of course, there is always the benefit of stroke risk reduction with closing the appendage, which is undeniable. And that's the only reason why I would want to maybe close it on a regular basis if
Gotcha.
reasons applied.
Sure. Another hot area is the vein of Marshall, ligament of Marshall. We know that there's ethanol. We know you can divide it epicardially. What about the application of cryo for the ligament or the vein of Marshall?
It's a great question. So obviously, epicardially, the coronary sinus is not large enough to most times accommodate a cryo balloon inside of the structure. Having said that, we're also about to publish our experience with inserting the cryo balloon into the coronary sinus and
Okay.
ablating it in large dilated coronary sinuses, especially in patients who have persistent left SVCs. It becomes quite feasible.
Sure.
But certainly ablating the vein of Marshall, that's not going to work with a cryo balloon. So you'd have to resort to alcohol septal ablation if you believe in that strategy. There's compelling data again out of several labs. Miguel Valderbano, as you know, among others, have shown some benefit to this. And there's currently an ongoing study to specifically look at this in a prospective manner as an adjunct to your standard posterior wall and pulmonary vein isolation by my colleague Luigi DiBiase and his team and colleagues who are working with him to look at this. So I think there'll be more exciting data that's going to emerge in the next couple of years on this topic, and we'll find out if there's benefit to it or is it again just could be like, for instance, routine appendage ligation as we saw with the AMAZE trial that didn't necessarily pan out.
Sure. Sure. Okay. Perfect. Well, I'm sure we're all going to be looking forward to those results. As a surgeon who likes to perform AFib surgery, unfortunately, I know I'm not 100% at it, right? I try my best. I put all the lesions where I'm supposed to. I do them for as long as I'm supposed to, but inevitably there's going to be some failures. Can you talk about what you've seen as an EP colleague? When you see surgical failures, where are those failures and how do you treat those with cryo?
It's a great question. I think the most important thing to point out is you want to pick a cardiac surgeon who's experienced at it, somebody like yourself, somebody who does a lot of it. Individuals who sort of dabble in this are the ones who are going to invariably have challenging results and poor outcomes, to be honest. And what we found is individuals who are regular at this, doing it on a regular basis like you are, get good results. And having said that, all of us can be challenged by not being able to sometimes ablate parts of the posterior wall to achieve complete contiguous lesion sets on the posterior wall. Now as you said, have the ability to map as we're performing the procedure, so we can see it in real time and be able to adjust the dosing application and additional applications as needed necessary to complete the job. But that's where we tend to see a lot of times the posterior wall not being completely silent when it comes out of surgery. I think surgeons like yourself who do a lot of it do a fantastic job of the pulmonary veins. And I think, as you indicated, also other additional spots, like for instance, the vein of Marshall, ligament of Marshall, and closing the appendage is a big add-on benefit, which many patients enjoy. Many of them can't tolerate blood thinners, or for a variety of reasons are not good candidates for it, and this obviates the need for taking long-term blood thinners. We routinely, again, don't do that in conjunction to our ablations, excuse me, and so that becomes a limitation of our procedure as compared to yours.
So generally speaking, would you say as surgeons, we should maybe focus more on the floor lesion, if you will, that posterior wall floor lesion between the inferior pulmonary veins? You think that's maybe our weak spot?
You know, to be honest, I've seen sort of a medley of outcomes, and I think,
Okay.
you know, in some cases, I've seen the posterior wall in the middle part, the mid portion, not being completely isolated. Other individuals, I've seen maybe the lower part. So I think it's sort of like electrophysiologists as well have maybe certain, I hate to say weaknesses, if you want to call it that, or whatnot, or strategies that are maybe slightly different. But that is probably a common location, as is also with electrophysiologists who perform posterior wall isolation. For us, the limitation happens to be the esophagus in the line of fire, and that happens to be in the middle of the posterior wall sometimes. And we tend to go lighter a little bit there, and there happens to be the site of reconnection as well. So I think you guys are not unique in it, but certainly I think if you emphasize more applications there, it would probably lend to more efficacy in that region, I guess I would say.
Gotcha. Okay, well, since we're talking about the posterior wall, why don't we jump right into your study? Obviously, you're the principal investigator of the pivotal IDE study. Can you talk to us about kind of the why this study is so important to do right now?
Well, thank you for that. Yeah, so it is called the pivotal IDE trial. It's a prospective randomized multi-center multinational IDE trial, and one of the things that we're sort of proud about it is that it's designed in such a way that it hopefully will answer the question in a very scientific manner. It's really a double-blinded study, and you might say, how could it be double-blinded if you're the operator and you know
Right.
what arm the patient's allocated it? So the reason why it's double-blinded is because we during the course of the study we will randomize patients to PVI versus PVI with posterior wall isolation. And the randomization piece to posterior wall ablation will not be assigned until the pulmonary vein isolation part has been completed. So once the patient has been put through or subjected to pulmonary vein isolation and that part of the procedure has been completed, then the operator is made aware of whether the patient is randomized to PVI only or PVI with posterior wall. And we think it's a very scientific sort of a design, if you would, of a study as the studies go, in order to answer this sort of $1 million question, or is the posterior wall really valuable over and beyond the PVI piece that has been shown to be the cornerstone of AFib ablation therapy. The good news is a number of other retrospective and smaller scale prospective studies have shown the posterior wall to be of benefit. But this is a multi-center, larger scale, multinational study that will hopefully shed light on this once and for all for us.
You know, I when I was reading through the actual parameters of the study, I found it very brave to include 7 to 14-day ambulatory monitoring. You know, we all typically go by this HRS definition of 24-hour Holter, less than 30 seconds, no antiarrhythmic drugs. I thought that was pretty courageous. Can you tell us a little bit more about why you chose to even have more scrutiny on the rhythm success of this procedure?
Because you know, honestly, we think, you know, there's the better the monitoring, the more likelihood of actually capturing some arrhythmias that are meaningful in this case. And I do think that there is potentially a bias in this, that the posterior wall does play a role. And I think a lot of it really does come down to monitoring. One of the limitations of, for instance, a lot of the paroxysmal AF studies is that the studies are challenged by the type of follow-up that is associated with them. People have said, in fact, over the years that, you know, if you look at the trend and the outcomes of many of the paroxysmal AF studies, they're sort of all about the same, regardless of whatever strategy or procedure is being performed. And people have in fact raised the concern that could that just simply be a reflection of our ability to identify AFib recurrence more so than actually assessing the results of the outcome of the treatment strategy. So we tried our best to be as pure as we could to really look for as many arrhythmia episodes as we could, short of having to force operators to implant loop recorders, which is really the holy grail. If you really ask me, that's really the ideal way of assessing the outcomes of two strategies that are being compared head to head. Since we didn't have the luxury of being able to do that, we pushed the envelope by asking folks to do the longer term monitoring.
Gotcha. Okay, that makes a lot of sense. So where are you with enrollment now? When do you think you'll be finished, and when can we get these great results?
Thank you. So we recently started to enroll a number of patients. I think we've so far enrolled 7 or 8 patients, I want to say, and
Okay.
we're on our way to basically goal is to enroll 366 patients. We have 2 interim analyses. So we'll see what they bring, and if we need to actually go to all the way to completion of 366 patients to get the results that we need to see. But at this point, we have about 14 sites that have that are going to be coming online and getting started, and they're at various stages of their enrollment as we speak. So we're hoping in the next 2-3 months we'll be really revved up, ramped up, being able to start cranking out a number of patients. We were hoping that this is going to be completed within a couple of years' time from the onset of enrollment at our site, which took place a couple of months ago.
It's fantastic. You know, I'm sure you're aware, but just for the listeners also, there's a parallel surgical study going on called the cryo study. So, you know, everyone's very interested in cryo right now and seeing if these cryo lesions, not just the lesions themselves, but the energy source also works better than the other modalities we have available to us right now. So gosh, well, that was a quick shot, fascinating kind of review of cryo. Is there anything else you'd like to impart to the listeners about specifically maybe your technique, since you've done so much of this, or anything else that somebody should know about cryoablation?
Really, just that I think cryoablation is a tool like any other. And I think if you're comfortable doing good work with be it radio frequency ablation or laser balloon or whatever the modality of choice that may be, I think at the end of the day, it's just another tool. We've happened to sort of get comfortable with this particular technique and strategy that we've adopted, and it seems to work well for us. But I really have nothing against using other strategies. And along the same lines, I still, as we said earlier before, I think there is potentially a role at many centers for hybrid strategies, which could incorporate either cryo or RF into it to achieve the most successful outcome for our patients.
Well, that's fantastic. I really appreciate you coming on here. I know you're super busy clinically. Dr. Aryana, it was an absolute pleasure.
The pleasure was mine. Thank you for your time and for listening.
Thank you.
Thanks again. Have a good afternoon.
You
Bye-bye.
too.